Visible now?
Yes, it is. It
Okay.
is.
There must be some technical glitch. Right. So let me just go through it. Now it's got stuck. Okay, so in the next half an hour or so, we will just discuss very briefly about the baseline nutritional status and how it influences our way of thinking, because actually it impacts upon everything: the quality of life, the patient's compliance, the toxicity profile or spectrum that we get to see, and of course it impacts upon the outcomes in terms of local regional control and even survival. There are enough and more studies which have shown that all those who are malnourished, they tend to perform poorly, both in terms of control of the disease and in terms of the survival status of these cancer patients. The site also impacts upon the nutritional status of these patients. It has been seen that mostly all patients will have some degree of malnutrition, but usually it is mild or moderate. You get to see severe malnutrition more often in upper aero digestive tract and GI malignancies. There are multiple causes why this malnutrition is so often encountered, and usually it is because, one, the ages. Usually we see these cancers in elderly. They usually are seen in lower socioeconomic class, where the awareness or the affordability is not good, and so their nutritional status is inevitably poor. Similarly, their oral hygiene is poor, and that also leads to malnutrition. They are usually more frequently habituated to alcohol and tobacco. That also works. And then when they present in advanced stages, malnutrition is a consequence of that. Then the treatment that we offer, which we are going to talk about, that is mucositis and all, is also does also contribute significantly towards malnutrition. All this works at a molecular level, and cytokines are released, which impact upon the immune system and lead to something that we call as cachexia. Cachexia has very defined definitions in the literature, that there is a pre-cachectic stage when the patient would have lost about less than 5% of his or her original weight. Two, it can move on to cachexia, where the weight loss is around 10% or more, or there is BMI, dramatic fall in BMI is encountered, or sarcopenia, that is a muscle loss, significant muscle loss is there, or and so on and so forth. And that could be further go on as refractory cachexia, and that could even be one of the final contributing factors towards death. So cancer cachexia or cachexia is not the same as starvation, which lots of time fasting individuals do encounter, because both cachexia and starvation have loss of body weight and mass and body fat. But because cancer, the cachexia component is usually when there is catabolic activity and there is negative nitrogen balance. So you also encounter that the resting energy expenditure is higher and the protein degradation is much more in cancer cachexia. So it is again occurring at multiple molecular level, where there is cytokine production on one hand, leading to eliciting systemic inflammatory response. Then on the other, there is proteolysis, and all this leads to appetite, depression, release of chronic inflammatory markers, alteration of the macro environment, decreasing the bone mass, leading to weight loss, inflammation, fat depletion, muscle wasting, and poor clinical outcomes. So malnutrition, when encountered, has a spectrum of downstream effects that one may see, and those could be that these individuals would be they would have an increased risk of infection. Their post-operative healing would be impaired and may lead to complications, and there could be they would not tolerate routine cancer-directed therapy well, or the tumor response would be suboptimal. Of course, if there is a baseline malnutrition, then the cost also would increase because you need to build up. So there is cost angle to it also. Then there is the general condition is low, and the patient, instead of coming walking to the hospital, may have to be brought in a van or a wheelchair or something. So all these are not just cost burden, but social burden also increases, and it reduces the quality of life of not just the patient, but also of the caregivers. We must measure the nutritional status, and we'll see when, but there are various parameters, and our nutritionist colleagues will be able to tell us and teach us better. Usually weight loss is one parameter that we have to document and measure. Unfortunately, even today, when we look at our document case records and all, we find that people are the kind of population that comes to us, they're not able to give us what was their weight like 6 months back. So the degree of weight loss, accurate measurement of that is usually not possible. So most of the time we find that we are looking at what is, by the dietary recall method, what is the calorie deficit like? Is it more than 500 kilocalories per day, or is it less than that? What is the protein deficit like based on the body weight of the person? So we need to calculate the body mass index in each one of them to look at the nutritional status, to look at the dose of, say, chemotherapy agent. So we really need these parameters at a different juncture. So there are various tools present to document malnutrition, like the malnutrition screening tool, which is a multi-step screening tool, or there are others like patient-generated subjective global assessment or subjective global assessment, SGA tool, or mini nutritional assessment tools. There are quality of life measures which have nutritional domains present in it, and we need to work on them to identify how malnutrition has impacted the quality of life of the patient before, during, and after treatment. Like we said, treatment does impact the nutritional status in a very big way. All major modalities like chemotherapy, radiotherapy, and surgery all have their own impact on the nutritional status of the patient. So if we look at modern radiotherapy, which is like growing by the year, and we have sophisticated tools, they take care of the patient's tumor quite well, and they also they try to, the newer tools and newer techniques are there to decrease the morbidity or toxicity. But we must not we must understand that radiotherapy has certain basic principles. For instance, if we see in this particular area, there would be a large mucosal area which we are going to include in this patient in radiotherapy, because that the entire mucosa may be just an innocent bystander, because the tumor is sitting right next door, and you have to include the nodes and so on and so forth. So we have to, there is a large area which is subjected to radiation, and therefore undergoes inflammation and mucosal reactions and ulcerations. All those we get to witness. Alongside with that, lot of tumors, we also have to give concurrent chemotherapy protocols, so that adds to the toxicity considerably, and there is a synergistic phenomenon. So what are the nutritional problems that we encounter in radiotherapy? Acha, before I go any further, we must understand that radiotherapy is not like a surgery. It's not like one day procedure that aaj aap aaye, surgery hui and ek hafte baad aapki chutti ho gayi. It is not like that. It's like a 1.5 to 2 months procedure. Every day the patient has to walk into your hospital, is there for 2 to 3 hours. The radiation per se takes 10 to 15 minutes inside the room, but then the entire procedure saps a lot of energy out of the patient, and plus these mucosal reactions that I just described to you. So all in all, these patients very often tend to face anorexia, nausea, taste loss, food aversion, fatigue, mucositis, weight loss. A lot of weight loss is there during radiation, and we need to be very careful. Not only do we face problems, nutritional problems in these patients uh, before radiotherapy, because that's when the treatment has not started and the tumor itself was causing problem, nutritional problem, because of the physical obstruction of tumor. Sometimes the patient is unable to take. Then while you're investigating the patient, you're taking care of dentition. There are dental extractions happening quite often in the upper aero digestive tract tumors. Then again, the patient is unable to eat. So there are malnutrition problems that we encounter. During radiation, I've just described. And then once the radiation is over, then there are sequelae that we face, the patient faces, like dryness of mouth, swallowing difficulties, and they all lead to their own set of downstream problems, like the speech gets impaired, the taste is gone, the pH of the mouth is changed, there is so much of dryness that leads to the enamel erosion of the the teeth, and so dental caries set in, swallowing becomes difficult, and because of the swallowing difficulties, patients oftentimes face aspirations which are silent to start off with, and may lead to subsequent frank clinical pneumonias, and recurrent pneumonias may cause failure to thrive and even death. So it's not a small problem. Like I said, there is dryness of mouth after radiation. So this is a study from published from our department. What happens is, when you are giving, if you look at this line in blue, this is the radiation portal, and if you look at these salivary glands, they are actually innocent bystanders in this particular case, where the tumor is lying somewhere in the upper aerodigestive tract, and we have to treat that tumor and the lymph node bearing regions, and the parotid and the submandibular and sublingual glands come in the way, leading to they dry up subsequent to radiotherapy, and that leads to permanent or temporary damage to the salivary gland, leading to dryness. Similarly, aspiration is very often encountered. In fact, our own study has shown, and so have other studies, that about 2/3 of the patients tend to aspirate, even though silently, after chemoradiotherapy. And that's not a small problem, because that's a major killer, and there's nothing that you can do except for preventing it and rehabilitating these tumors back with a lot of rigor. So it's not, we sometimes have burnt our fingers also, and lots of people, that mortality which you may encounter at a later date can be very high, and unacceptably so, because these are toxic treatments the patient may not tolerate. So you need to select your patients well, provide them proper infrastructure support, use better and better techniques and machines, and of course, take care of the nutrition all the way, before, during, and after, if you want these patients to pull through these particular long drawn treatment strategies like radiation. So what we do, this is just a bit of a technical thing, where again I'm trying to make you aware. So we make these thermoplastic casts, which the patient has to wear while the patient is receiving radiation at that particular particular time point for about 10-15 minutes. The patient wears it and then it is removed. So this cast is made when we are planning for radiotherapy. So if a patient, say, has 60 kg weight and you make a cast, so that is, the cast is made as per the patient's head and neck area. He or she cannot move, at least that part cannot move while the radiation is on. So you tend to give the radiation in a very precise manner, just to the tumor and not to the adjoining structures as far as can be helped. But what happens is, sometimes because of the mucosal reactions, because of their lack of awareness, because of lack of financial support, a variety of reasons, patients inevitably tend to lose weight. Sometimes they lose so much of weight that the cast becomes loose and their neck and mouth can move a little bit while the patient is on treatment. And that can be naturally counterproductive, both from the point of view, you want to treat the tumor, but you're also treating the adjoining area, is what happens. So that's a big technical challenge for us. And that's why we are very particular that these patients do not lose more than 5% of their weight while they are on treatment. Similarly for chemotherapy. Now, chemotherapy, unlike radiotherapy, is not like everyday affair, but then it is given sometimes weekly, depending upon the schedule, sometimes 3 weekly. And inevitably, we all know that these patients are, the chemotherapeutic agents are also highly emetogenic, and so they lead to a lot of emesis and appetite loss and distaste. And because there is inevitable marrow suppression with chemotherapeutic agents, so they are prone to infections also, and that also worsens the matter. So you get a host of symptoms, nutritional problems that you may encounter based on anorexia, nausea, taste loss, aversion of food, etc. The same story actually holds true for surgery also. Patients who are the ones in red, who are prone to, who have severe malnutrition, are prone to multiple morbidity at the time of surgery. Post-op period can be very turbulent for such patients, and the mortality is, of course, unacceptably high when we are dealing with a patient who's been operated and has baseline severe malnutrition. So when should these patients receive nutritional assistance of any sort? There is enough and more evidence which has shown that all diagnosed cancer patients should undergo nutritional screening at baseline and at multiple time points during treatment and during follow-up. All patients who have documented significant malnutrition should have not only just screening, but nutritional intervention. And that may include enteral feeding, which is what I'm going to also talk about. And plus regular diet counselings from professional nutritionist colleagues. So nutritional therapy actually plays an integral role in oncology treatment of cancer patients, and it is definitely required to improve the prognosis and reduce the number of cancer-related deaths in these patients. Coming to enteral feeding, that is that's a very huge tool that we have to prevent further downhill course, a nutritional course in these patients, and all undernourished patients who are on treatment should be the threshold towards putting in enteral feeding access should be very, very low. All patients where we are expecting that the energy expenditure would be less than 10% for more than 10 days, less than 60% for more than 10 days, should actually look for either a nasogastric tube or a percutaneous endoscopic tube, or what is also known as radiological tube, gastrostomy tube that you may put directly in the stomach. anytime before, I mean, when the tumor is still present before treatment or early part of treatment, when it is physically obstructing the nutritional passage, you should again opt for enteral feeding. Surgery is, of course, an important area where inevitably nasogastric tubes are put. And we do not recommend in dying patients. Our threshold again rises actually when the patient reaches the terminal phase, because their time nutritional requirements are low. We are looking for giving comfort to such patients. So we did a small survey a few years back, and it was a cross-sectional study where we looked at the baseline level of these cancer patients who reported to our dietary clinic, and looked at the demography, looked at their dietary recall method and their nutritional status. We found that most of them came from the sixth decade of life. Males were common, and the 12% comorbidity was encountered in these patients. So their ideal body weight as per their age and height and everything was about 60, average was 62 kgs, but the mean weight that they were having was 55 kg. That means there is a good 10% less than what an ideal weight should have been. Most of these tumors that we included in this survey were belonging to the aero digestive tract, that is the head and neck or ENT tumors, and the stomach esophagus. It was seen that before even the radiation or chemotherapy was started, there were swallowing problems that these patients encountered in about 20% of patients, and there was mucositis and vomiting, and significant amount had loss of appetite also. 1/3 of these patients actually needed semi-solid diet from the very beginning of treatment. So you can imagine, normally we see patients eating solid when we start off treatment, and then they go on to liquid, and then they say, "Nahi, ab nahi khaya jata, nigla nahi jata." But 1/3 to pehle se hi dalia khichdi and semi-solid diet le rahe. So you can imagine ki how difficult it is to give them their regular feeds. What we saw in these patients was that 36% of them were malnourished at the beginning, and the calorie deficit of more than 500 kilocalories that went into their system every day was about 60% of the patients. Similarly, protein deficit, the daily protein that they were to take, by dietary recall method, it was seen that more than 15 grams of deficit was seen in nearly 60% of cases. So we are dealing with an unending problem, and we have to constantly work on it. And we've also seen that the more the percentage weight loss, if it is 10%, then you can expect a high mortality figure. And if it is hovering around 5%, then the mortality figure also decreases with if you are able to maintain weight. We reviewed the results of our study and compared it with the literature, and we found that yes, our patients were encountering significant amount of malnutrition, especially the head, neck, stomach, esophagus patients. That led to poor quality of life. The lesson that we learned is that we must keep counseling them, must following them during treatment, after treatment. That's a very important part. And when we need to transition from semi-solid to semi-solid, when we need to put in an enteral feed, when do we stop treatment just to give rest to the ulcerated mucosa. So clearly the problem is to the tune of 40 to 50%, and it has long-term prognostic implications. And so we need a greater and greater nutritional support. They form inevitably the vital component of our part of our team on day-to-day basis, and so that we can think of giving them about 25 to 30 kilocalories per kg body weight, which is what we just heard in the previous lecture by Dr. R.K. Singh. Similarly, proteins have to be maintained, and fats also, including medium fatty chain triglycerides. We must also understand that as Indians, the magnitude of problem is actually even worse. The studies have shown that amongst both adults and children, the anthropometric indicators of nutritional status are amongst the worst in the world. So we have to imagine that as it is baseline, our nutritional status is not good. And the cancer is on the rise. We have about 25 lakh cancer patients in our country. 3/4 of them are advanced. So the cancer obstructs. So what is the actual degree of malnutrition is actually mind boggling. It is there, and we have to, it's an elephant in the room. We can't sort of wish it away. What happens when the patient reaches during the terminal phases? That's when we try to be gentle. We are not over enthusiastically overcompensating, because even that is a load on a shutting down system. So we ask, we train the caregivers that you give small feeds, give them frequent but not too frequent. Just feed them in sitting position, because aspiration is a very big problem in these patients. So the take-home message, I would say, is that we are dealing with a high prevalence of malnutrition in cancer. Actually, we can only discuss or look at the tip of the iceberg. And there are multiple factors which also include treatment, because that treatment is equally a culprit as the diseases and as the patient's body habit is. We need to start thinking about nutrition very early during the course of illness, and because they need support at each step, because malnutrition does impact outcomes in significant way. So that is what I had to say regarding patients who are cancer patients who are on any form of cancer directed treatment. If there are any queries, I'll be happy to take.